Let's move on to discuss radiation therapy for cancer. The purpose of radiation therapy is to destroy cancer cells, but minimally damaging surrounding normal cells. So maintaining a safe environment for not only the patient's normal cells, but also healthcare employees who are helping that patient. Radiation can be used to cure, control, or palliate the disease. Radiation therapy is a very localized treatment. It is not systemic. So the effects of radiation are only seen in the path of the treatment. Only seen where the radiation actually touches the body. It's given in a series of divided doses, and this could be daily, and it can be used along with other therapies. Radiation that we use for cancer is ionizing radiation. As cells are exposed to ionizing radiation, the material in the cell's nucleus is rearranged. This is either going to kill the cells outright or make them unable to divide. Gamma rays are the most commonly used because they are deeply penetrating. They go deep into tissues. And beta particles can be used as well, but they need to come into closer contact with the cells that are to be treated because the beta particles are weaker. When we're discussing radiation therapy, we might talk about exposure and dose. Exposure is the amount of radiation delivered, whereas radiation dose is the amount of radiation absorbed. So the dose is always going to be less than the exposure. Absorbed radiation doses are measured in units called gray, and that's abbreviated GY. The dose of radiation is going to depend on the tumor size, the tumor location, the tumor sensitivity to radiation, and so those are going to be the three factors that influence dose are going to be intensity, duration, and the closeness of the radiation source to the cells. So those three factors are going to determine how much of the radiation is absorbed, which is the radiation dose. We've got a couple different types of delivery methods for radiation, and the choice of radiation method is going to depend on a patient's general health and size, the size, shape, and location of the tumor. So teletherapy is when the source of radiation is outside the patient's body. So because the source is external to the patient is not going to be radioactive and won't be hazardous at all to another person. Some of the patient care issues that we might see with teletherapy is when someone has teletherapy, they're going to have to be put in the exact same position for each therapy. So when we do this, we have to be very careful that someone is lying in the exact same position, and they might end up using splints and braces. They might make body molds to make sure someone is in the exact same position each time. They even end up tattooing people. Many of you maybe have seen, especially women who have been treated for breast cancer with small tattoos on their breasts, and that's going to be because of the teletherapy. Brachytherapy is when the source of radiation comes in direct, continuous contact with the patient. So what that means is that the source of radiation is actually within the patient. It delivers a high dose of radiation to the tumor and a lower dose to surrounding tissue because it's actually touching the tumor. So brachytherapy uses radioactive isotopes in either solid form or put into body fluids. So if we're talking about liquid form or radioactive isotopes going into body fluids, one example of this is going to be radioactive iodine that might be swallowed to treat some thyroid cancers. So these liquid forms of brachytherapy are either ingested or instilled into the body, like if we would want to put it in like the peritoneal cavity. That's one way to do it as well. Because we do this, because it's ingested or instilled in fluid form, it actually makes the patient and their body wastes, like urine, feces, sweat, tears, radioactive and a potential hazard to others. Some device implants is another aspect of brachytherapy. We consider these device implants, sometimes they're called like seeds or needles, and they can be actually directly implanted into the tumor. So these solid implants are going to emit radiation, but the urine and feces or the excreta of the patient is not going to emit these hazards. Chart 22-1, which is called the care of the patient with sealed implants of radioactive sources in your 8th edition of IGGI, which is on page 376, is a good chart for that. Some side effects of radiation therapy are listed here. With radiation therapy, we can't avoid damage to surrounding tissue. Acute changes are going to be these local skin changes and hair loss. They're of course going to vary depending on site. We could see almost burns on people's skin. Depending on where it is, we could see altered taste sensations. Fatigue and bone marrow suppression, of course, are going to be seen. Table 22-2, acute and late site-specific effects of radiation therapy in IGGI 8th edition is on page 376. Some long-term consequences of radiation therapy, for example, if we have radiation in the throat or upper chest, we might see changes in swallowing that might not really resolve. We could see xerostomia or really dry mouth, and that could cause difficulty swallowing. All of this could lead to malnutrition, which are going to be long-term effects of radiation therapy. Any bone that's exposed to radiation is going to be not only at risk for bone marrow suppression and then of course immunosuppression and other blood cell suppression, but they're going to be at high risk for breaks as well. Like I discussed, we're going to see those local skin irritations. That's generally more acute, but we need to be sure that we're educating our patients on good skin care. Chart 22-2, skin protection during radiation therapy, which is on IGGI 8th edition, page 377, is a really good one. There are some tissues that are more sensitive to external radiation. Like I keep stressing, those bone marrow cells are pretty sensitive. Skin cells, mucous membranes, hair follicles, and sperm and ova are also very sensitive. Let's continue talking about patient-centered collaborative care for these patients receiving radiation therapy. We're going to have to do a really good job providing accurate information and educating our patients as well as their family members. I discussed about the skin care during radiation therapy. We need to educate patients that if they don't have a permanent tattoo or ink marking, they cannot remove their temporary ink markings that help show where the radiation spots should be. They need to avoid skin irritation by really taking good care of their skin. And oftentimes oncology is going to have their own policy for what should be used on a patient's skin after radiation, including sometimes prescription creams or compounds. Nutritional support is going to be very important, like I discussed, especially if we're talking about radiation to the head, throat, neck, upper chest. That could cause some problems with difficulty swallowing and lead to malnutrition. We need to help care for that xerostomia or dry mouth and educate patients about things like sucking on sour candies, not sweet candies, to help them stimulate saliva production, and using ice if that's easier to suck on ice chips, constantly keeping themselves well hydrated, using things like biotin as a mouthwash, teaching patients about being at risk for fractures, especially when their bone has been exposed to radiation. And we have to talk to them about exercise and sleep interventions for fatigue, especially building up to exercise, as they are going to be tired and potentially have bone marrow suppression and therefore anemia, so they might be even more tired. Dietitians and physical therapy, as well as, of course, speech therapy and occupational therapy, are going to be important multidisciplinary aspects of this care as well.